Welcome to the deep dive. Today we're tackling a really fascinating and, well, often talked about subject, hyperbaric oxygen therapy, or HBO2,
That's right.
and specifically its potential in treating neurological conditions. Now, you, our listener, shared a really detailed chapter with us, Neurological Aspects of Hyperbaric Medicine from Hyperbaric Medicine Practice.
Hmm.
So our goal in this deep dive is to really get under the hood,
Right.
understand what the scientific evidence presented in this textbook actually says about how HBO2 might help with various brain and nervous system issues.
Exactly. And the basic idea, boosting oxygen delivery to damaged brain tissue, it's definitely appealing. It feels like it should work.
It makes intuitive sense, yeah.
But, as we always try to do here, we need to really dig into the data, see what the rigorous research actually shows. And this textbook chapter, it gives us a great starting point for that.
Okay, let's unpack this then. Starting with stroke, or as the chapter calls it, cerebral ischemia. For anyone listening who might not be totally familiar, what exactly is going on in the brain during an ischemic stroke?
Okay, so think of it almost like a plumbing problem, but in the brain.
Right?
An ischemic stroke happens when a blood vessel gets blocked. And that blockage, it cuts off the supply of oxygen and nutrients to a particular area of brain tissue.
Okay.
Now, right in the center of that area, the infarct core, we call it, brain cells die incredibly fast, within minutes.
Wow.
And this is really critical. There's an area surrounding that core. It's called the penumbra.
The penumbra, right?
Yeah. In this zone, the blood flow is reduced, but it's not completely gone. So the cells there, they're vulnerable, they're struggling, but they are potentially salvageable.
Ah.
If, and it's a big if, we can get adequate blood flow restored quickly.
And as it stands right now, the textbook points out there's really only one FDA-approved treatment for this specific situation, tissue plasminogen activator, TPA.
That's it, TPA.
What are the limitations we need to be aware of with TPA? I know there are some.
Oh yeah. The big challenge with TPA is the incredibly tight time window. It really needs to be given within the first few hours after the stroke symptoms begin.
Just a few hours.
Right. That's the window to dissolve the clot and get blood flowing again.
Huh.
If you wait too long, the risks associated with using TPA can actually start to outweigh the potential benefits.
Which is where maybe other therapies come in.
Exactly. This is where researchers and doctors have looked at other potential therapies like HBO2, thinking maybe it can help improve oxygen delivery to that at-risk penumbra.
Okay.
And maybe also, reduce some of the damaging inflammation that happens after a stroke.
Right, the secondary effects. Now, here's where it gets, I think, really interesting. The chapter goes into quite a bit of detail about animal studies. What did the research on mice, rats, gerbils, even cats tell us about HBO2 and stroke?
Well, the findings from these preclinical studies were actually pretty encouraging, quite promising, really.
Yeah.
The vast majority of them showed positive effects when HBO2 was given after the animals had an induced stroke. They saw things like a smaller area of brain damage. The infarct size was smaller. They saw improved neurological function in the animals afterwards, and even better survival rates in the groups that got the HBO2 treatment.
And what kind of treatment are we talking about? Like, how much pressure?
Typically, these studies used HBO2 at a pressure of about 2 to 3 atmospheres absolute. So, think maybe 30 to 60 feet underwater pressure.
Right.
And usually for about an hour.
And it sounds like timing was just as critical in these animal models as it is with TPA in humans. That seems to be a theme.
Absolutely. Crucial. The animal data really hammered home this idea of a therapeutic window. It suggested HBO2 was most effective if it was given within the first 6 hours after blood flow was restored to the brain.
6 hours, okay.
Treatments given much after that point generally didn't show much significant benefit, if any. And there's even a suggestion that if the blood vessel stayed completely blocked, that window might be even shorter.
Wow, okay. So beyond just, whether the animal did better overall, did the researchers see specific positive changes, like at the tissue level in the brain itself?
Yes, they did. And this starts to give us some clues about how HBO2 might be working.
Right.
So in the animals treated with HBO2, they saw less shrinkage of neurons, less swelling or edema in the brain tissue, less actual dead necrotic tissue.
Uh-huh.
And importantly, fewer signs of apoptosis. Now, apoptosis, that's like a programmed self-destruct sequence for cells.
Right, cell suicide, basically.
Exactly. So this suggests that HBO2 might somehow interrupt that chain of events, that apoptotic cascade that leads to brain cell death after a stroke.
That's fascinating.
And there was even some evidence that if the animals got HBO2 before the stroke was induced, It offered some kind of protective benefit.
Pre-treatment helping, huh? Okay, so with all that promising data from the animal studies, what happened when they tried it in humans? It sounds like the picture gets, well, a bit fuzzier.
That's definitely the case. Yeah, more complex. While some of the very early studies in humans maybe lacked strong controls, this chapter focuses on 3 pretty significant randomized controlled trials.
Okay.
The first one, Anderson and colleagues, they treated patients up to 2 weeks after their stroke.
2 weeks. That seems late compared to the animal data.
It does. And they used multiple HbO2 sessions, but at a lower pressure, 1.5 ATA. And bottom line, they didn't find any difference in the size of the stroke or the patient's neurological exams after 4 months.
Okay, what about the others?
Then there was Negagosian and their team. They treated patients within 24 hours, so a bit earlier, but still outside that 6-hour window.
Right.
They used a single 60-minute session, again at 1.5 ATA, compared to a sham treatment where patients just breathed normal air. And they also didn't see a difference in overall function at 1 year. There were maybe some very minimal improvements on a couple of specific neurological scoring scales, but really not much effect.
Okay, so 2 studies, not much luck. What about the third?
The most recent one mentioned, by Rusviniak and others, they did use a slightly higher pressure, 2.5 ATA, still just a single 60-minute treatment within 24 hours. But they compared it to patients breathing 100% oxygen at a slightly increased pressure of 1.1 ATA.
Wait, so the control group was getting 100% oxygen, not just normal air?
Exactly. You picked up on that. That's a really critical point.
Right.
They were getting quite a bit of extra oxygen themselves.
So maybe not the best comparison.
Well, interestingly, in that study, the control group actually showed better outcomes on some of the functional ability measures.
Better, not just no difference.
Better on some scales, yeah. Which definitely raised a question about whether there might have been some, unintended negative effect from that specific HbO2 protocol.
Yeah.
Although, to be fair, the main statistical analysis, the intention to treat analysis, didn't show a significant difference between the groups overall. But it certainly makes you pause and think about, well, what are the ideal parameters for HbO2 in stroke, if there are any?
It really sounds like there's a disconnect here, doesn't it, between the animal promise and the human reality so far. The chapter points out some key limitations of these human trials, right?
Precisely. And they're really important. First off, as we touched on, all 3 of those major studies enrolled patients well outside that critical 6-hour window suggested by the animal research.
Way too late, maybe.
Possibly. Treating someone days or even weeks after a stroke might just be too late to have a significant impact on damage that's already, well established.
Okay.
Secondly, 2 of the studies used that relatively low HbO2 pressure of 1.5 ATA. For other conditions where HbO2 is helpful, higher pressures are often the standard.
Right.
And third, as you pointed out, the control groups in 2 of the studies got higher than normal oxygen levels, which could have potentially masked any real benefit in the HbO2 group, made it harder to see a difference.
It's interesting that the chapter brings up heart attacks, saying HbO2 has shown benefit there in acute coronary syndrome.
That's right. In the context of a heart attack, HbO2 has been shown to help get more oxygen to the damaged heart muscle and limit the amount of injury.
So why the difference?
Well, it really highlights that the body's response to HbO2 can vary quite a bit. It depends on the specific organ, the type of injury, the timing. It's complex.
So putting it all together for stroke, it sounds like the current verdict is, well, not recommended for routine treatment.
That's the clear conclusion from this chapter, yes.
Yeah.
The authors really emphasize that there's a need for well-designed human studies that give HbO2 much earlier, within those crucial first few hours.
Yeah.
Using higher pressures probably, and definitely having appropriate control groups breathing normal air. Until that kind of research happens, the potential role for HbO2 in ischemic stroke, it remains an open question. Needs to stay within research protocols for now.
Okay, very clear. Let's shift our focus then to another challenging neurological issue, radiation-induced cerebral necrosis, or RIN. What exactly is this? Why is it a concern after brain radiation?
Yeah, RIN is a serious complication. It can develop months, sometimes even years, after someone has radiation therapy for brain tumor.
Months or years later.
Yeah, and it causes progressive neurological symptoms. Things like cognitive problems, memory loss, trouble concentrating personality changes, or specific neurological deficits like weakness or speech problems. And a major challenge is that these symptoms can look a lot like the original tumor coming back.
Oh, wow. That must be incredibly difficult to distinguish.
It is. It's a major diagnostic challenge.
The chapter mentions different phases of injury after radiation. Where does RIN fit in? Is it immediate?
No, RIN is considered a late effect. You can get some immediate effects from swelling right after radiation, usually reversible, and some early effects, maybe weeks or months later, also often reversible. But RIN develops much later, typically months to years after the radiation, and unfortunately, it's usually not reversible. It's progressive damage.
And you said telling it apart from tumor recurrence is tough, even with good imaging.
It's exactly things like MRI spectroscopy, PT scans, SPECT scans. They can offer clues by looking at brain metabolism and blood flow.
Uh-huh.
But often, the only way to be absolutely sure is with a brain biopsy. Pathologically, what you see in RIN is the death of white matter tissue and damage to the small blood vessels.
Ah, the blood vessels again.
Yeah, the current thinking is that radiation damages the endothelial cells lining those tiny vessels. That sets off a chain reaction leading to reduced blood flow ischemia and eventually tissue death, necrosis.
And treating REN sounds like it's pretty difficult.
It can be very challenging. Surgery is sometimes an option. There's been some limited success with antithrombotic medications, things that prevent blood clots, but these have risks and limitations.
Okay.
But what's interesting, and this is where HBO2 comes in, is that HBO2 has actually been quite successful in treating radiation injuries to other soft tissues in the body, like in the jaw or pelvis.
Right, I've heard of that.
And the thinking is, since damage to blood vessels and reduced blood flow seem to be key factors in RIN2, maybe HBO2 could offer a similar benefit in the brain. Improve oxygen levels, promote healing in those damaged vessels.
Okay, that makes sense conceptually. What does the research specifically show for using HBO2 for brain RIN?
Well, the evidence here is less extensive than for stroke. There's one small randomized controlled study mentioned by Holshoff and colleagues. They looked at cognitive problems in patients who'd had brain irradiation at least a year and a half earlier.
Okay.
They gave them 30 HBO2 treatments at a fairly high pressure, 3.0 ATA. They found a trend towards improved cognitive function, but it wasn't statistically significant.
A trend, but not quite there.
Right. However, the chapter also points to several individual case reports and smaller series of patients that have shown more encouraging results. Anecdotal evidence, but still interesting.
The Warnick series sounded quite positive, though. A larger number of patients.
Yes. That's probably the largest case series mentioned, although the full details were initially presented just as an abstract. They treated 29 patients with worsening neurological problems from RIN. They used HBO2 at 2.5 ATA for quite a while, 20 to 60 treatments.
Yeah.
And the majority, 27 out of 29, showed improvement in their symptoms. They were able to reduce their steroid doses, and some even had improvements on their MRI scans.
That sounds pretty good.
Yeah, and interestingly, they noted that patients who'd had radiation for benign conditions seemed to respond particularly well. We also have work by Chuba and colleagues looking specifically at children with RN who weren't getting better with steroids. It was a small study, just 10 kids, but all 10 showed either clinical improvement or at least stabilization after getting HBO2.
So for RN, it sounds like maybe there's a stronger case to be made for considering HBO2, even if the top-level randomized evidence is still kind of limited.
That's a fair way to put it, I think. The chapter concludes that HBO2 should be considered as a treatment option for RIN, especially if other medical treatments aren't working or if surgery isn't really feasible.
But more research needed?
Oh, definitely. The authors rightly emphasize we absolutely need more robust evidence from larger, well-designed randomized controlled trials to really nail down its role and figure out who benefit the most. But it's definitely on the table as something to consider.
Okay. Let's move on to another major area. Traumatic brain injury, TBI. This is unfortunately really common. What are the main challenges in treating TBI effectively?
Yeah, TBI is a huge public health issue, a leading cause of disability globally.
Yeah.
Now, the initial physical damage, the hit itself, that's often irreversible.
Right.
So the main focus of treatment right after a TBI is really on preventing and managing the secondary injuries, the damage that happens in the hours and days after the initial trauma.
Secondary injury, okay. What causes that?
A major contributor to poor outcomes is cerebral ischemia, not enough blood flow to the brain. This often results from low oxygen levels, hypoxia, and low blood pressure, hypotension, which are common right after the injury.
And down at the microscopic level, what's going wrong in the brain cells during the secondary phase?
It's a whole cascade of damaging events. You get disruptions in the balance of electrolytes like calcium and potassium inside the cells. The cell membranes themselves get damaged. There's something called excitotoxicity, where there's an over-release of certain neurotransmitters that harms the cells. Problems with how the brain uses glucose for energy.
It sounds like a mess.
It is. And all this leads to swelling in the brain, edema, and ultimately brain cells die. through both necrosis, which is just messy cell death, and that programmed apoptosis we talked about earlier.
Okay.
And then, if you get increased pressure inside the skull, maybe from the swelling or from bleeding, that just makes the blood flow problem even worse. It's a vicious cycle.
Traditional treatment for TBI used to be mainly supportive care, right? But it sounds like the focus has shifted.
Absolutely.
Yeah.
Supportive care, making sure the patient is breathing okay, maintaining blood pressure, that's still critical. But the field has made huge advances in intervening earlier to try and prevent or reverse those secondary injury mechanisms.
How so?
There are now established protocols for aggressively managing low blood pressure and low oxygen levels, and specific treatments for increased intracranial pressure, the pressure inside the skull.
Okay. So where does HBO2 fit into the thinking for TBI?
Well, the rationale is that HBO2 could potentially address several of those key secondary injury factors. It could improve oxygen delivery to the injured brain, obviously. It might help reduce brain swelling, the edema. And maybe, like we saw discuss with stroke, it could reduce the amount of cell death, particularly apoptosis.
Right, because there's evidence HBO2 can decrease edema and apoptosis after ischemia.
Exactly. So the thinking is maybe it can do the same in the context of TBI-related ischemia.
The chapter mentions some studies actually looked at intracranial pressure, the ICP, during HBO2 treatment in TBI patients. What did they find there? Was it helpful?
It's a bit mixed, actually. Some of the earlier reports raised some concern because they noted temporary increases in ICP during the HBO2 sessions.
Oh, this doesn't sound good.
No. But other studies reported mild, but more persistent, decreases in ICP in some patients. And one study even found that this decrease in pressure seemed to correlate with the patients getting clinically better.
Interesting.
But unfortunately, other markers, like trying to measure cerebral blood flow directly, haven't shown really consistent or reliable changes with HBO2 and TBI. So ICP is sort of an ambiguous finding.
Okay, what about the studies that directly compared HBO2 to standard medical care, head-to-head comparisons in TBI patients?
Yeah, there have been a number of those, but again, somewhat mixed results, which makes it tricky. One of the earlier ones, our True and colleagues, they treated patients who were in a coma, averaging about 4.5 days after their injury. They saw some trends, not statistically significant, but trends towards a shorter time in coma and a higher rate of regaining consciousness in the HBO2 group.
Okay, a trend.
Interestingly, though, in a subgroup of younger patients who had specific injuries to the brainstem, they did see a significant improvement in their level of consciousness after 1 month.
Okay. Any others?
There was an older study from the 70s by Holbach. It reported significant improvements in both mortality rates and the proportion of patients having a good outcome on the Glasgow Outcome Scale. This was in comatose patients with a specific severe type of brain injury.
That sounds quite positive. What about more recently?
More recently, a larger trial by Roxwold and their team. They enrolled patients pretty early, within 6 to 24 hours of injury, all with severe injuries based on their Glasgow Coma Scale score. They found no difference in the overall outcome among the survivors at 12 months. But they did see a significant decrease in mortality at 1 year in the group that got HBO2.
So fewer deaths, but the survivors weren't necessarily functioning better.
That seems to be what that study suggested, yeah. And then the smallest but most recent trial, mentioned in the chapter, showed something quite different again. It reported a markedly larger percentage of patients having good outcomes at 6 months in the HBO2 group compared to standard care alone.
Wow, that sounds really promising.
Yeah.
So why isn't HBO2 standard care for TBI then if some studies show fewer deaths or better outcomes?
That's the million-dollar question, isn't it? The chapter highlights several really important limitations with the research body as a whole.
Like what?
Well, a key issue is blinding. None of these studies were properly blinded. The researchers, often the patients, the families, they all knew who was getting the HBO2.
Yeah.
And that lack of blinding can really introduce bias when you're assessing how someone's doing.
Right, the placebo effect or observer bias.
Exactly. Also, many studies didn't use a true sham control, something that mimics the treatment experience without the active ingredient, making it hard to account for potential placebo effects from just, getting extra attention and care.
Yeah.
And on top of that, there's just a lot of variability between the studies. Who they enrolled, how soon after injury they started treatment, the exact HBO2 pressures and timings they used. It's all over the map.
Makes it hard to compare apples to apples.
Very hard. And while a meta-analysis, which combines results from multiple studies, did suggest a positive effect of HBO2 on mortality and TBI, the overall quality and the differences between the individual studies really limit how strong a conclusion we can draw from that.
So the takeaway for TBI, it sounds like it echoes what we heard for stroke. There's potential, maybe, but we really need more rigorous research.
Exactly. That's the bottom line from this chapter. We need larger, well-designed studies. Studies that use proper blinding, use appropriate sham controls, and maybe standardize the protocols a bit more before HbO2 could be routinely recommended for TBI.
Okay. Let's move on to a condition that is incredibly close to many people's hearts. Cerebral palsy, or CP. The chapter mentions right off the bat that using HbO2 for CP is a really controversial topic. Why is that the case?
Yeah, it's highly controversial for several reasons. Firstly, as the chapter points out, cerebral palsy isn't one single disease. It's really a group of disorders.
Right, an umbrella term.
Exactly. It has various causes, but the common factor is a difficulty with movement and posture due to some kind of non-progressive problem or injury in the developing brain. This variability between kids makes it inherently challenging to study treatments effectively.
Okay.
CP presents with a wide range of motor impairments, often spasticity, and frequently comes with other neurological issues too. And while the underlying brain issue doesn't get worse over time, the symptoms can certainly fluctuate.
And standard treatment is mostly about managing symptoms.
Right. Traditional management focuses on therapies like physical therapy, occupational therapy, medications to manage spasticity, all aimed at improving function and managing the symptoms.
So where did the idea of using HbO2 come from? The chapter discusses a theory by Dr. Neubauer about idling neurons. What was that about?
Yeah, Dr. Neubauer's theory was based on looking at SPECT scans, a type of brain imaging that looks at blood flow and metabolism. He looked at patients who had brain damage from lack of oxygen, from closed head injuries, and from stroke. Notably, not specifically children with CP.
Okay.
And he suggested that maybe some brain cells in damaged areas weren't dead, but just sort of idling, functioning at a very low level, but potentially capable of recovery. He reported seeing increased metabolic activity in these areas on the scans after HbO2 treatment in those specific patient groups.
So he thought maybe HbO2 could wake up these idling neurons.
That was the idea, even though these findings came from studies on different conditions and were often just observations in small numbers of patients without strong controls.
Right.
This theory, this concept of idling neurons, was used as a rationale, a justification, for trying HbO2 in children with cerebral palsy.
Okay, so that was the theory. What about the actual studies? What do the studies that specifically looked at HbO2 for kids with CP show?
Well, unfortunately, there are very few well-designed studies here. There was one pilot study by Montgomery and colleagues. It didn't have a control group, wasn't blinded. They reported some improvements in motor skills and spasticity in kids with a specific type of CP, spastic diplegia, after HbO2. But, without a control group.
Hard to know what it means.
Exactly. Then, the same group did conduct the only randomized controlled trial mentioned. It involved 111 children. They compared HbO2 at 1.75 ATA to a sham treatment. The sham involved the kids breathing normal air, but at a slightly elevated pressure, 1.3 ATA.
Okay, a proper comparison, finally. What did they find?
They found that both groups showed improvements across various measures, motor function, working memory, attention, but there was no significant difference between the HbO2 group and the sham group.
No difference at all.
No. The researchers themselves concluded that the benefits seen in both groups were likely due to placebo effect, or maybe just the effect of being involved in the study getting extra attention.
Interesting, but I think you mentioned the sham treatment itself might have been questionable.
That's right. The study has been criticized because the sham involved breathing air at 1.3 ATA. That slightly increased pressure means the kids were actually breathing air with about 28% oxygen instead of the usual 21%.
Ah, so it wasn't quite normal air.
Correct. And some argue that even that small increase in oxygen, that mild hyperbaric air condition, could potentially have had some real therapeutic effect itself, which might have masked a benefit from the 1.75 ATA pure oxygen treatment.
Complicated. Were there any other studies mentioned?
There was another uncontrolled study mentioned that used what they called low-pressure hyperbaric oxygen therapy, which was just air at 1.3 ATA, similar to the sham in the other study. They used it for kids with a very broad diagnosis of cerebral hypoperfusion, which included some children with autism as well as CP. Parents in that study reported some benefits, particularly for the autistic children. But again, it was uncontrolled, unblinded, very hard to draw from conclusions.
So for CP, the evidence seems to lean pretty strongly against HbO2 being clearly beneficial based on the best available study.
That's the general consensus reflected in this chapter, yes. The only well-designed randomized trial showed no significant benefit over a sham, that itself might have had some effect. And the presence of a potentially large placebo effect is a major concern in this population.
Right.
So most reviewers and experts agree that much more rigorous research would be needed before HbO2 could ever be recommended for cerebral palsy. And as we just touched on, the same really holds true for autism.
Let's move on then to multiple sclerosis, or MS. This is another area where there was apparently a lot of initial interest in HbO2. What fueled that early hope?
Yeah, back in the 80s and 90s particularly, there was a lot of buzz around HbO2 for MS.
Why then?
Well, primarily because back then there were far fewer effective treatments available for MS, especially for the progressive forms of the disease.
Oh, okay.
MS, as you know, involves inflammation and damage to the myelin sheath, the protective covering of nerve fibers in the brain and spinal cord. This leads to a whole range of neurological symptoms. While we now have much better treatments for the common relapsing remitting form,
Right.
treatment options are still pretty limited for people with the progressive forms. So back when options were scarce overall, several early non-randomized reports came out suggesting that maybe HbO2 could have a positive impact on disability levels in people with MS. That generated quite a bit of hope.
But hope isn't data. What did the more scientifically rigorous studies, the randomized controlled trials, ultimately find?
Right, so a significant number of randomized controlled trials with various designs were actually conducted to investigate this properly.
Okay.
These studies typically enrolled patients with a definite diagnosis of MS, often people who were in a stable phase, without recent flare-ups or exacerbations. The HbO2 doses varied a bit, pressures from 1.75 to 2.5 ATA, but a common protocol was around 2.0 ATA for 90 minutes, maybe 20 treatments or so.
And what were they measuring? What outcomes?
They looked at a variety of things. The EDSS, the Expanded Disability Status Scale, which is the standard measure of disability in MS. They also looked at things like bowel and bladder function, pyramidal function, basically muscle strength, and reflexes, the frequency of MS attacks or exacerbations, and even objective measures like evoked potentials or changes on MRI scans.
So pretty comprehensive assessments. What was the verdict?
Well, the key finding, really, across the majority of these numerous studies is pretty clear. Only one small study, involving just 34 patients, showed any significant difference that favored HbO2.
Only one.
Only one. And even in that study, it was just a temporary decrease in EDSS scores at the end of treatment and at 6 months. But that difference was gone by the 12-month follow-up.
Not a lasting effect.
No. 2 other studies reported some very minor improvements in a couple of specific secondary outcomes, things like sphincter control in one and then maybe pyramidal function in another. But these are small effects on secondary measures.
So it sounds like the vast majority of these trials just didn't show any real benefit from HbO2 for MS.
That's accurate. For most of the outcomes they measured, including the main disability scales like EDSS, there was just no significant difference between the groups that got HbO2 and the groups that got a sham treatment.
Okay.
There was even a large registry study mentioned involving over 300 MS patients, and it also failed to show any significant improvement in EDSS scores after HbO2. And when researchers have pooled the data from multiple trials together in meta-analyses,
What did they find?
the overall conclusion has consistently been that there is no significant effect of HbO2 on the clinical presentation or the progression of MS.
And what about the placebo effect? Was that seen here too?
Oh, definitely. Interestingly, many patients in the placebo or sham groups in these studies actually reported feeling better, which really highlights the potential for a strong placebo response in this particular patient population. People want to feel better, and participating in a trial can sometimes lead to perceived improvements.
The chapter also points out something about the stage of the disease and the patients who were enrolled in these studies. Was that potentially a factor?
Yeah, that's an important consideration to mention. The majority of these studies included patients who had chronic or more advanced MS. They already had significant disability, often with average EDSS scores, indicating they needed help with walking, like a cane or walker.
So maybe it was too late by then.
Well, that's the question the authors raise. While the strong evidence we have clearly argues against a benefit for HbO2 in these later chronic stages, they do acknowledge that it hasn't been definitively proven that patients in the very early stages, or those with milder forms of MS, wouldn't experience any benefit.
But based on current evidence.
Based on the overwhelming body of evidence available, especially from all those randomized trials, the conclusion is pretty firm against any broad application of HbO2 for MS, as it's typically seen in clinical practice.
Okay. Finally, let's turn our attention to autism spectrum disorders, or ASD. This is another area where HbO2 has gotten a lot of attention, maybe more in the popular press and among some parent groups than in the scientific literature.
You're absolutely right. There's obviously growing public awareness of ASD, which is good. But unfortunately, this has also led to the widespread promotion of many, frankly, unproven or poorly supported treatments. And HbO2 is definitely one that comes up a lot.
Yeah.
Families, understandably desperate for anything that might help, sometimes report spending really significant amounts of time and money on therapies like HbO2.
But the chapter seems skeptical about the underlying science.
Very skeptical. It emphasizes that there's really no established biological mechanism, no clear reason why simply increasing oxygen levels in the body would alleviate the core behavioral symptoms that define autism. The link just isn't there theoretically.
And what does the actual research show? Is there any evidence?
Well, according to this chapter's review, the evidence is currently extremely weak. The authors identified only one randomized controlled study that even suggested a benefit of HbO2 in children with autism.
Only one?
Yes, and they specifically noted significant concerns about the methodology of that particular study, which really makes its findings questionable, likely flawed.
So, not strong evidence. What else?
Beyond that, there have been some smaller, uncontrolled case reports. Doctors reporting on a few patients where they observed some clinical improvements in symptom scores after HbO2 treatment.
But uncontrolled means?
It means you can't be sure the improvement was due to the treatment. Without a proper control group for comparison, without blinding, it's impossible to determine if those improvements were a direct result of the therapy or maybe due to the placebo effect, other interventions happening at the same time, or just the natural course of development.
So the recommendation regarding HbO2 for ASD is pretty cautious, it sounds like.
Extremely cautious, yes. The chapter concludes very clearly that HbO2 should not be recommended as a treatment for autism spectrum disorders. Not that we have much more conclusive long-term positive results from well-designed, rigorously controlled clinical trials. The current evidence simply does not support its use for this condition, period.
Okay, so let's try and summarize this whole deep dive then. We've gone through the evidence for HbO2 and several neurological conditions based on this textbook chapter.
Right.
It seems like the overall picture is, well, while there was some promising initial data, particularly from animal studies in areas like ischemic stroke.
Right. The preclinical work looked good sometimes.
The findings from human clinical trials just haven't provided that clear, convincing, irrefutable evidence for its routine use, not really for any specific neurological disease we've discussed today.
That's a concise and, I think, very accurate summary of what this chapter presents. The animal data certainly gives a rationale for maybe looking harder at HbO2 very early in ischemic stroke.
Yeah.
But the human trials so far, largely negative, or at best inconclusive.
Yeah.
Often hampered by limitations in their design, the timing of treatment, the oxygen dose.
Right.
For radiation-induced necrosis, RIN. There's perhaps more suggestive evidence, especially as maybe a salvage therapy when other things fail. But we still need bigger, better studies.
Yep.
Traumatic brain injury, TBI. Some studies hinted at benefits, especially maybe reducing mortality. But again, the overall quality of the evidence just isn't strong enough yet. Needs more work.
And then CP and MS.
Cerebral palsy. The only good randomized study showed no benefit over a potentially active sham. Multiple sclerosis. The overwhelming evidence from numerous trials points to no benefit, at least in the chronic stages most often studied.
And autism.
And for autism spectrum disorders, the evidence supporting HbO2 is currently, very weak and unreliable, really not recommended.
And it's really crucial to remember, as the chapter points out quite clearly, that none of these neurological conditions we've talked about, stroke, RIN, TBI, CP, MS, ASD, none of them have received FDA approval as established indications for treatment with hyperbaric oxygen therapy.
That's a critical point to underscore, absolutely. While HbO2 is an approved and effective treatment for a specific list of other medical conditions, things like decompression sickness, certain infections, problem wounds,
Right.
its use for these neurological disorders remains largely in the realm of research and experimental investigation, not standard practice.
This has been a truly fascinating, although maybe, at times a bit sobering, look at the science behind hyperbaric oxygen therapy and its potential role in neurology. It really highlights that often quite significant gap between promising findings in the lab or in animals and getting conclusive evidence from human studies.
That certainly does. It's a common story in the medical research, unfortunately.
So, as we wrap up this deep dive, here's something for you to consider, our listener. Given the potential that has been suggested in some areas, like maybe very early stroke or TBI mortality, and the fact that research is always ongoing, what future approaches, maybe in study design or perhaps more precise ways of selecting which patients might benefit, could finally help us understand if, and maybe where, hyperbaric oxygen therapy might truly have a role to play in treating diseases of the brain and nervous system? Something to think about.
Thanks for exploring this complex topic with us.